As you will see in this chapter, tricuspid regurgitation is a very frequent finding. And the most common cause is annular dilatation, in other words, a dilatation of the right ventricle. One thing, however, I never really understood was why some patients have huge right ventricles but only mild TR, and other patients have huge amounts of TR and only very small right ventricles. So this probably is related to the anatomy of the tricuspid valve and the variation in the anatomy. But now, let's start from the beginning. Trivial is a very frequent finding. You will find TR in approximately 70% of adults. Here's such an example. You can see a very small jet in the region of the tricuspid valve. So this, for sure, is very insignificant TR. But significant tricuspid regurgitation, in other words, TR moderate to severe, is also a fairly frequent finding, at least in a patient population that has a mean age of 67 years. If we then look further what the cause of significant TR is, then we see that the functional cause is more frequent than the primary. We'll talk later what we mean by functional and primary tricuspid regurgitation. Is the presence of TR relevant for the patient? Yes, it is. Here is a graph which shows you the different degrees of TR with respect to survival. If you take a look at patients who have severe or moderate TR, then you can also see that their survival is poor. So, yes, tricuspid regurgitation is an independent risk factor for death. And this is true, independent whether the patients also have pulmonary hypertension or not. Of course, patients who have higher pulmonary artery pressures have a poor survival. But even in patients who have pulmonary artery pressures, for example here below 40 millimeters mercury, we have poor survival if tricuspid regurgitation is severe or moderate. So it's quite clear from the literature that patients who have significant TR have a poor survival, especially in the setting of pulmonary hypertension, reduction of left ventricular function, and reduction of right ventricular function. And it's important to understand that there's a strong interplay between all these factors: tricuspid regurgitation, left heart problems or reduction in left ventricular function, pulmonary artery pressure, right heart problems, and right ventricular function. So, in reality, those patients who are right here in the middle, who have all these problems, are the ones who have the poorest prognosis. It is well established that patients who have, for example, mitral valve prolapse or a functional form of mitral regurgitation often also have tricuspid regurgitation. This shows you what happens if we only operate on the mitral valve and don't operate on the tricuspid valve. Very frequently will we see a progression to grade 3 or grade 4 in patients who initially only had mild or moderate TR. So those who were treated had much less tricuspid regurgitation than those who were untreated. What does that mean? We know that TR progresses, and we know that we have to operate these patients also for the tricuspid valve. We have to be fairly liberal with respect to our indication for operation of the tricuspid valve. Okay, so now we know that TR is bad. But why do patients get TR in the first place? Well, the most common cause is functional TR, which means that the valve is structurally normal. The problem is that we have an increase in the size of the tricuspid annulus related to dilatation of the right ventricle. Since the septal leaflet is fairly well fixed to the septum, it is the anterior and the posterior part of the leaflets and the ring, of course, which move laterally and are displaced and thereby cause dilatation of the ring. Usually we have an increase in the size of the ring and in the orifice area in patients who have functional TR. In contrast to the mitral valve, the subvalvular apparatus is not involved, so we very rarely see restriction of the leaflets. Here's an example of a patient who has typical functional tricuspid regurgitation. Why? Because the patient has dilated cardiomyopathy. We can see the reduction in left ventricular function here. And the patient also has a dilatation of the right ventricle, which leads to tricuspid regurgitation. But there are also many other problems of the left ventricle which can lead to dilatation of the right ventricle. For example, coronary artery disease, mitral valve disease, pulmonary hypertension, an atrial septal defect with significant left to right shunt, and tricuspid regurgitation itself causes a dilatation of the right ventricle, which then increases the degree of tricuspid regurgitation. In other words, we have a vicious cycle. Much less frequent will we see a structural problem of the tricuspid valve as a cause for tricuspid regurgitation. Which causes are there? Rheumatic heart disease, trauma, pacemakers, endocarditis, carcinoid heart disease, and congenital heart disease. Here are some examples. Here's a patient with rheumatic heart disease, with rheumatic mitral stenosis, but also rheumatic tricuspid stenosis. You can see the turbulent inflow into the right ventricle as an indication for the presence of tricuspid stenosis. But in addition, the patient also has tricuspid regurgitation. The problem in these patients is that the combination again increases the gradients across the tricuspid valve because we have more flow back and forth across the tricuspid valve. Therefore, TR in the presence of tricuspid stenosis is not good for the patient. This is an example of a patient with a fairly rare cause for tricuspid regurgitation. This was a 48-year-old male who had a car accident which led to rupture of the tricuspid valve. We have a flail leaflet here with a broad coaptation defect in the transthoracic echocardiogram. And we can also see the rupture here in the transesophageal echocardiogram. When does that usually occur? Well, it occurs in blunt chest trauma. As a matter of fact, the tricuspid valve is the valve which is most frequently affected in car accidents or in chest trauma simply because of its anterior location and also because it appears to be more fragile. Over the years, we've seen approximately 5 or 6 of these patients. The interesting thing is that not all patients were symptomatic right at the beginning when they had the rupture. Some patients showed symptoms of right heart failure many years after the accident. So, if you have patients with an unclear cause of tricuspid regurgitation, always ask them if they had a blunt chest trauma in their history. Tricuspid regurgitation is very frequent in the setting of ICD or pacemaker leads. We know that approximately 20% of patients develop some form of abnormal tricuspid regurgitation, in other words, more than trivial or mild after implantation. Approximately 4 to 5% even develop severe tricuspid regurgitation. We also know that patients who have an ICD more frequently than patients who have normal pacemakers develop TR, and that TR progresses over time. Here's an example of a patient with pacemaker leads in the right atrium and right ventricle, where we have at least moderate tricuspid regurgitation. What are the causes for tricuspid regurgitation? Well, either it's impaired tricuspid valve closure, it's associated especially with patients who have numerous leads, it can be associated with injury, but also with infection, in other words, pacemaker lead infection, which also then involves the tricuspid valve and destructs the tricuspid valve. Since more and more devices are implanted, we also more frequently see this problem, the problem of tricuspid regurgitation. We haven't yet covered the topic on endocarditis, but I'm sure you immediately recognize what the problem is here. We have a large mass on the tricuspid valve, which leads to destruction of the tricuspid valve and rupture and thereby tricuspid regurgitation. Here's one such patient, and here's another patient where you can see a very long vegetation which freely swings between the right ventricle and the right atrium. Probably we also have a flail leaflet here. So another cause for tricuspid regurgitation is endocarditis of the tricuspid valve. You will hear more on this topic in the chapter on endocarditis. A much less frequent cause for TR is carcinoid heart disease. Why do we have TR? Because of the serotonin which is produced by the tumor. Especially if the tumor also has metastasis in the liver, then we have very high concentration of these substances, and they destruct the endocardium. They cause endocardial fibrosis. So they affect the tricuspid valve, but also the pulmonic valve and the right ventricular endocardium. Why are the left heart structures not affected? Because serotonin is metabolized in the lung. Only if we see a PFO or an atrial septal defect will we have levels of serotonin which can cause destruction of structures as, for example, the mitral valve. Here's a beautiful example of a patient with carcinoid heart disease where we see the typical pattern of involvement of the tricuspid valve. We see a broad coaptation defect and the typical thickening of the leaflets and the leaflet restriction. The leaflet does not move at all. Without even using the color, you can imagine that the patient has significant high-grade tricuspid regurgitation. So in summary, the typical features of carcinoid heart disease are leaflet restriction, a wide coaptation defect with severe tricuspid regurgitation, endocardial fibrosis, and on the pulmonic valve, we usually or more frequently see stenosis. The picture is sometimes so typical that we can make the diagnosis of carcinoid syndrome just based on the echo. We've done that on several occasions. I would now like to talk about congenital abnormalities of the tricuspid valve, which can lead to tricuspid regurgitation. In general, I'll be talking about morbus Epstein, but be aware that we also have dysplastic valves or dysplasia of the tricuspid valve, which can, to the extreme, also be an overlap to a morbus Epstein. Here we have a nice example of a patient with morbus Epstein. We see a very long anterior leaflet, leaflet tethering. You can see how the leaflet is attached to the myocardium here. We have apical displacement of the leaflet, so the point of closure is far within the right ventricle. And we have atrialization of large parts of the right ventricle. In other words, functionally, this is part of the right atrium. Here we see the same patient from an apical view. Again, apical displacement of the valve, long anterior leaflet, short septal leaflet, and a large functional right atrium. Be aware that the morphology can vary in patients with morbus Epstein, and there's actually a classification which helps us classify the different types of morbus Epstein, and which are also important for the surgeons to determine if and how these valves can be replaced or repaired. Expect to also see other pathologies in morbus Epstein, such as an atrial septal defect, very frequently actually, a ventriculoseptal defect, a patent ductus, coarctation, RVOT obstruction, and also arrhythmias, because very frequently do these patients also have accessory pathways. The issue of dysplastic valves is not very well understood and very well investigated in humans. In the literature, we find much more in the animal world. I found reports about dysplastic valves in Florida panthers, in monkeys, in dogs and cats. In any case, you should suspect a dysplastic valve if TR is moderate in the absence of other primary or secondary causes for TR. And remember, probably dysplastic valves are a rudimentary form of a morbus Epstein. So in conclusion, and coming back to the statement I made way at the beginning of this chapter, there is a high variation in the morphology of the tricuspid valve, and maybe someday in the future we'll be able to determine which patients have a predisposition for the development of tricuspid regurgitation if the right ventricle dilates.